The question was, how do you select a health coach?
Okay, so I think one, and this from personal experience, I think one, you need to identify your problems, right? Like in terms of like what's going on, what do you need help with? Because you just go, oh, I just want weight loss, or maybe you need more than like. Figure out exactly what you like. Take time and go, what are my goals? What am I trying to achieve with this, right? And then, so that's number one, identify your problems and what you're trying to fix. Number two is get to know the person. A lot of people will see like really flashy colors and like good ads. You know, remember these people pay thousands of dollars, including myself, on education and things like that to make things look good, attractable, all that fun stuff. Don't fall for that, right? Take your time and get to know them. Listen to their content, see what they're about, okay? So those would be my two big ones. And then have conversations with them and figure out if it makes sense, and then go for it. Those would be my three big things.
Published results.
That's a very doctor answer. You see the difference.
You all don't have to answer the same question.
Okay, go to the next.
Oh, so I will say this also. Some people may disagree with me. If they start telling you this person has been a client for 5 years, still trying to lose weight or still trying to figure things out, that may not be the best person. At least it depends on what you're trying to accomplish, but when we coach, my job is to get you to the point where you don't need us anymore, right, to figure it out. So when you see someone like, well, I've been using the same coach to lose the same 50 pounds for the last 3 years, maybe it's time to find a different coach, you know? But if you're in a situation with Jonathan where you're trying to work on hormones, it may take longer. But their ultimate goal should be to get you to the point where you don't need them anymore. Okay, question for Dr. Bikman. Is there an association with the big fat cells and lipedema or lymphedema?
Okay, yeah. So with lipedema, more and more I'm convinced it's not a disorder of fat at all, of the fat cell per se, but rather the collagen and the extracellular matrix around it. So lipedema is a very different thing than lymphedema. In fact, they're not even related. So I'll just, lymphedema just being a swelling because there's too much fluid that's coming out of your fat cell, or sorry, out of the cell, or out of the blood vessel, I'm sorry, out of the blood vessel, but it's not getting pulled into the lymph. And that can be a result of any number of things, including electrolyte imbalances, protein imbalance, and lymph blockage. That's lymphedema is a number of different causes. Lipedema is, I believe most accurately, and I can use the word believe here because there's a lot that is unknown on this, as much as it pains a scientist to use that word. And never just believe the science when it comes to anything as if it's a declaration of faith, which I respect as a man of faith. But with lipedema, every cell has around it what's called an extracellular matrix, extra being out, extracellular matrix, fat cells included. And when fat cells are bunched together, each of them has its own very minute extracellular matrix. And collagen is a part of that, and it just gives substance to the fat tissue. The reason a woman starts to typically a woman, overwhelmingly a woman, will experience this is because the high levels of estrogen that will occur during puberty and pregnancy will activate a protein called TGF-beta, tissue growth factor beta. One of its consequences will be to take the modest amount of collagen in the matrix that's surrounding the fat cells and make it into a thicker wall of collagen, which begins to both literally pinch the nerves that are in that fat tissue, causing pain, and compress the fat cell, making the tissue itself very hard and very sensitive to the touch. But that's not because the fat cell is misbehaving, it's because the collagen around it is misbehaving. Why is her collagen responding, her extracellular matrix responding to her estrogens like that when another woman's isn't? I don't know. And indeed, I don't think anybody knows. So that's the limit of my answer, I'm afraid.
Dr. Bikman, what is the specific name of the blood test for FFA levels?
Yeah, in fact, it's going to be called free fatty acids or non-esterified fatty acids, NEFA. Tro, can you confirm from a clinical view, do you know?
Never tested.
Okay, yeah, it's very uncommon, to get even less common than insulin. If you're in Canada, you can forget about it. And I say that as a Canadian, but the healthcare system will in no way cover that for you. Here, it'll maybe be another $40. But it's going to be FFA or NEFA, and it'll be the same thing. Free fatty acids or non-esterified fatty acids.
When it comes to that test, is that something like, so we have like Dave Feldman with Own Your Labs, are those tests that we can put on there?
In fact, yeah, Dave, after hearing me give this talk, a version of this talk at a meeting before, he said he's going to add it to his list.
So if you didn't know, you can order a lot of your own blood tests, except for in certain states like New York. You can order a lot of your own blood tests. You don't even have to go to your doctor. And honestly, a lot of times it's going to cost you less money than your copay of going to the doctor and then the lab fees through ownyourlabs.com. So if you actually go to any one of our videos, there's a link on it. We make no money off of it. It's all about Citizen Scientist Foundation, but it will give you, I think, a 5% discount on any labs. And then if you agree to anonymously allow Dave to use your test results for his studies and for Citizen Scientists, you get another 10% off. I mean, we've gotten full labs, including NMRs, fasting insulin, for like less than $80. Like, I can't get that through insurance. So ownyourlabs.com. Jonathan, any tips for managing a fear around carb cycling?
That's a good question. So before I give an answer on that, preface, you need to understand, like, you have to weigh like your physical health over your mental health when it comes to these, again, nuanced topics, right? And realize that if you're not necessarily optimal, and you know you're not optimal, but you're not ready to take that next step, you don't take that next step, okay? That's really important. Don't force yourself into a spiral, right? That's not good. However, if you're like, okay, I'm ready to take this on, I think there's a couple things to think about. I think one, like avoiding trauma-associated foods. I cannot emphasize that enough, right? Like if you have a food or a vegetable or whatever you decide to include, and you have that's associated with some kind of trauma or binge eating or nostalgic memory that makes you want to eat endless amounts of it, or whatever that may be, avoid that food. I think that is paramount, okay? Secondly, you have to be willing to be open-minded, right? I think Dr. Tro talked about that too. Like you have to be open-minded to new things, new possibilities. And you really need to take time to try and understand. Think about it like this. Most people in this room used to fear fat, yes? Yes. Right? Now we love it. It's great. It's so good for you. It does so many good things. How did you learn to get over your fear of fat? You learned. Education and experimentation, right? How did you start knowing keto felt good? You tried it, okay? So first thing is education, like educating yourself, and educating yourself well from unbiased, published study-backed sources, okay? Right? Educate yourself, okay? And I don't mind, I can send you all the stuff I talked about. If you all want to see some of the studies I have to look at some of the more like objective truths in the theories that we talked about, I can do that, right? But educate yourself. Secondly, you need to experiment. You have to be willing to try new things and be okay with it. Like, I think about me, like, I got to a point where it's like, I'm going to try this, and if it doesn't work, then fine. It doesn't work, but at least I can say I tried. So many people fear just simply trying and failing, but the thing is that you're not a failure unless you quit on your health journey, right? Like falling is not failing. Falling is learning, and that's how we get better. So I would say, have self-awareness, and then you need to educate and then experiment and be willing to fall with grace.
This is for anybody who would like to answer it. How bad is it to have a high spike on your CGM if it has a rapid drop as well?
Like CGM goes up and then comes right back down.
How far does it drop? I think that's a hard question to answer, because I'd say if it goes up and then within an hour or so it's back to baseline, that's whatever you ate, your body actually responded well to it. That's what I would say.
Yeah. So a couple things. So the rapid decline is associated with postprandial hunger, meaning so there's a nadir after a rapid decline, and that's typically associated with hunger. So if you're trying to avoid hunger, you want to avoid rapid shifts. There's some data showing that a 50 to 60 point increase in blood sugar can affect the endothelium, cause damage. In terms of the most recognized endpoint, which would be, Bottom line is, if that's extended over a long period of time, that's probably the most data that will be problematic. That will lead to sort of end organ damage. And I think it also depends on the reason for the spike. So, you know, there's benefits to exercise, for example. So, you know, the biggest spike I've had in my life is when I ran a 5K race, and my blood sugar went up 100 points. Now, it was a stress on my body. Is that necessarily detrimental? I don't think it's great for me to have a spike up to, you know, 150 points, but there's some benefits to exercising and building muscle and, you know, doing races. So I think you have to take the nuance, right? You have to take in.
We're a good team. Yeah.
But there's more and more data showing that those spikes are actually problematic, and I would not be surprised if more data comes out showing that it's problematic.
Yeah.
Yeah.
Oh, I'm sorry, I know you were going to answer. Go ahead.
Yeah, probably Ben is the most qualified to answer this question. I think probably it depends of how high is the spike and how low it drops after. If it drops very fast, it can be also a sign of postprandial hypoglycemia, so insulin resistance, and that's where measuring insulin and monitoring it is very important. In general, we know that people who are high spikers, so have this pattern of high spike, have an initial insulin resistance. So it can be of concern, but it depends on other factors.
In fact, I have nothing to add. These are great responses. I would just make one comment with Tro's finding with exercise. Just be aware that every CGM is temperature sensitive, that the hotter it gets, the higher the number's going to get, and it's a total artifact of the technology. So if you're ever in a sauna and you're wondering why your glucose spikes, your glucose hasn't spiked. It's literally the temperature. So even with Tro's instance, it might be, although it might have been a cold day, and then
It's freezing.
yeah, so that's not it. So that was just pure just epinephrine all the way. But otherwise, it's just something to keep in mind that when temperature gets too high, it's going to start giving you a fake reading.
That's interesting enough, because I know that I've talked to Kim Howerton about that, both of us. Like when we were at CGM and get in a hot shower, because we both like really hot, like almost scalding showers, our glucose would go up on the CGM. So did not know that.
There's been a mistaken thinking that, boy, look at this metabolic stress. No, that's not enough. It literally is just a sensor giving you a bad reading.
And having it go up fasted isn't always a bad thing. You know, we've been fasted and we get in bed, and guess what? It goes up. It goes up, right?
There's a child here.
Okay, I didn't say anything other than we get in bed. And Jonathan's over here cheating, reading the questions ahead of time.
Well, it's a good one.
Okay, question. Where do I get a prescription for a CAC score?
In Utah, you don't need them. Frank, you just go to a clinic and pay.
Same in Florida.
48 states, we're licensed in 48 states. So happy to help wherever you are in the United States. So we made a practice literally for this. There was too many people unable to find doctors in each of their states. So we have, between myself and 2 other doctors and a PA, we are licensed all across the United States, a full metabolic clinic all across America. So.
What are the 2 states that you have?
Nobody cares about Hawaii or Alaska. Hawaii, we're coming. Okay. Alaska, well, maybe we'll be there on October.
So all of the continental United States.
Correct.
Awesome.
This one is for Jonathan. How would you recommend combating a GBS disease that attacks the adrenal system, making you diabetic at random whenever it feels, along with PCOS and high-stress PTSD that cannot be avoided? PCOS is so severe that I started cycling by age 9 and have not had a normal cycle being 32 now. Healthy diet and exercise or not?
So, I'll be honest, I'm actually curious to hear what the doctors have done. I don't know, I'll just be frank, I don't know what GBS is. I haven't heard of it. Something that's fine. Hmm?
Is it Guillain-Barré?
I'm not familiar with it.
Yeah, Guillain-Barré is a nervous system disease.
Yeah. Nervous system disease. Okay, so here's what I'll say. I want to hear what they have to say, but something like we talked about, like theoretical, like the practice, the things I specialize in. there's a lot of theory going on because it's just not studied and documented well. I'll look into it. I want to learn more. I love being educated more on some more unique conditions, but I don't have an answer. But I just want to make sure I said something because it was addressed specifically to me. But I don't have an answer for that right now. But stay in contact with me, reach out to me, whoever wrote that, and I promise I will find some answers.
What was the question again? Sorry, just repeat it. I got the GBS, the adrenal component, and wanted to hear.
They have a disease that attacks the adrenal system, making them diabetic, quote unquote, at random whenever it feels, along with PCOS and high stress PTSD that cannot be avoided. The PCOS is so severe that they begin their cycle at age 9 and have not had a normal cycle. They are 32 at this point. Healthy diet and exercise or not does not affect it.
Yeah, so like this is very complex, but I would tease apart all of those, right? So if you look at PCOS, very clear that low-carb diets are the superior diet for hormonal regulation in PCOS. That much is very clear. I think it'll be a standard very soon. The adrenal dysfunction in GBS, I just don't remember it, so I'll have to go look that up. So thanks for, giving me, showing me my ignorance.
Thank you.
Yeah, that's just, I'm gonna punt.
Well, yeah, I teach a graduate class in endocrinology, so I ought to be able to answer this very well. I'm unaware, so what it sounds like to me is an autoimmune condition. Guillain-Barré is often autoimmune.
Yeah.
However, the only autoimmune situation I'm aware of that involves the adrenal glands is Addison's disease, where it's a destruction of the adrenal cortex, not an activation. And if you're destroying the adrenal cortex, you would not be having hyperglycemia. You'd have a hard time keeping your blood glucose levels up, particularly in a fast, because if you destroy the cortex, you don't have cortisol, and good luck keeping normal glucose levels with a fasted or a ketogenic state. So this is almost suggesting like it's an activation, like a Graves' disease. So there are autoimmune diseases that stimulate the gland rather than destroy it, and that is exactly what Graves' disease does. It is entirely possible there's an adrenal-focused autoimmune disease that is stimulatory rather than destructive. Because we have an instance of it with the thyroid gland, so it wouldn't surprise me at all. I'm just not aware of it, but that would have to be what's happening here, if it is, in fact, the adrenal glands that are responsible for the diabetic episodes. There's a lot in that question that is a little confusing, so it's hard to really know the details, and a lot of this is the person's, it could be, I mean, I don't really actually know all the details going on in that person's body, but if it really were just at face value what is being stated, it would have to be some adrenal specific version of Graves' disease, where the autoimmune disease is activating the gland rather than destroying it.
I just want to add real quick. So while we do our research, some things to think about, I think, as I've been kind of just listening and thinking, Dr. Trobe, Dr. said, I think keeping a low-carb ketogenic diet is a good idea. I think with the PCOS and the PTSD, I think thinking about what Dr. D'Agostino said, supplementing with some ketones in this instance would not be a bad idea for right now. And then also environment, right? When we think about autoimmune, right? Like maybe check your house for mold. What are you putting on your skin? What are you washing your hair with? What kind of water are you drinking? Like, think about things that could be epigenetically affecting you and making negative impact. So those would be some things like for now that are just foundational that you can work towards.
Okay, so we have a question that is probably going to upset some people.
Yay.
If we cannot make fat cells bigger without insulin, then why do leaders say that you cannot just eat a stick of butter because you're going to gain weight? So in other words, there's lots of social media people or whatever say, you can't just eat gobs and gobs of butter on keto. So their question is, if you're not going to make your fat cells bigger without the insulin, why can't we just eat gobs and gobs of butter?
Well, yeah, okay, yeah. So I would say there's no one stopping you from but yeah, I mean, this is starting to touch on the question that I asked, which is this: it's never been done to actually take a group of people and put them hypercaloric to see. There have been overfeeding studies that has been done, looking at some of the metabolic adaptations to resist the weight gain, but it has never been low carb hypercaloric versus low fat hypercaloric. But the idea of going hypercaloric with fat, it's only been done in one study that I'm aware of, and the one that I cited, But no, I don't know why someone couldn't eat thousands of calories of butter. But we would have to know what their fasting insulin levels are. But if they're low, I would put smart money on the bet that they will not gain weight. There may be other complications, including that they stop digesting it very well, that they start to have compromised absorption and they get a fatty diarrhea. Assuming, however, that they are in fact absorbing every nutrient, every calorie from that butter, like I said, the body, if insulin stays low, the body will start making sufficient compensation or compensatory mechanisms to ensure that that cannot be stored as fat, including, most especially, those two variables I mentioned. Increased metabolic rate, which is a very real thing, especially if people want to only invoke thermodynamics, then you have to accept the fact that insulin will control metabolic rate. Yep. And then two, the energetic wasting in the form of ketones. But even the increased metabolic rate is itself a form of energetic wasting. You are, every biochemical reaction has a waste product of heat, giving us our warm-blooded bodies. The more that is happening, the more waste we have. Rather than energy being stored or burned in a working muscle, it's now just being spent as heat. So both of those represent a wasting. So all that would happen is the metabolic rate would continue to go up, ketone production would continue to go up to ensure that the calories are spent or wasted, because in the presence of low insulin, they cannot be stored. So if you want to test that with yourself by doing a high butter diet, I look forward to seeing the results, and I strongly suspect you will not gain weight. I also suspect it's going to be very hard to be hypercaloric. You're not going to want to keep eating. You're not going to want to push that. And that's part of the fact, when insulin is low, David Ludwig has shown this so well in his Harvard lab, when insulin is low, total energy availability is up. So the amount of ketones in an energetic molecule will be up. Glucose will be at a normal level. Free fatty acids will be high. So the brain is thinking, oh my gosh, we are loaded with energy. Stop eating. And so satiety will be at an 11 out of 10. So it will be very hard to overeat on butter. You're not going to want to do it, including just the fact that humans do not crave fat. A lot of these knuckleheads on social media who keep citing John Speakman's work, have you seen anyone doing this? There are some shirtless influencers who cite Dr. Speakman's work very often. All of his work is done in mice. Mice actually crave fat, and humans do not. This has been shown. No one is sitting around on a Saturday night craving a stick of butter. We don't do that. We want something sweet and gooey or salty and crunchy. And I'm not a coach or a clinician, and I even know this. I'm a lab rat scientist. So yeah, anyway, no one's craving fat. No one's craving protein. I mean, some here might start to, but even still, I think if they're really being honest, they're going to want something with carbs. Humans have only ever shown an addiction or a craving for carbs with fat or without it, but never fat alone, never fat and protein alone. So anyway, getting hypercaloric on butter is going to be very, very hard to do. Even if you somehow force yourself to do it, I strongly suspect you're still not going to gain weight.
So just to, I know we've talked about this, Ben, Jim Johnson's work may be so Jim Johnson's another sort of endocrinology researcher in Canada, and he did an interesting study with human beta cells, and I think he exposed them to different macronutrients. We talked about the problems of that, but potentially there's this idea that certain people may respond to different macronutrients by releasing more insulin. It's never been done in humans.
No, but Tro, another point on that, they treated with direct free fatty acids. And that's not the same as the triglycerides that are in the blood. Yep. So what he found, and he's at UBC, any phone from BC. So he took the beta cells and then treated them with direct free fatty acids. And free fatty acids have been shown to induce an insulin release, but that is not the same as what you've eaten, because when you eat fat, it's a triglyceride in a chylomicron. And that's how, when I looked at that study, as much as I appreciated it, I also kind of winced, because I thought people are going to take the in vitro model and make an assumption with the in vivo whole organism. But yeah, so free fatty acids can induce an insulin release, which is actually just a check. That's a mechanism whereby the body is trying to stop the excessive lipolysis, or the breakdown of fat. If you start to break down a lot of fat, that will increase, subtly at least, some level of insulin, which is going to try to stop slowing down the breakdown of fat. But that is, again, not the same as eating lipids, eating fat, which then gets moved around as triglycerides. That, to my knowledge, still has no effect.
Wait, real quick, just real quick, just because I want, from a coaching perspective, just real quick. I think something Dr. Bikman said really well, and you really need to listen to this. He said people that are insulin with low levels of insulin, metabolically healthy, could probably get away with chugging butter and not gaining fat. If you are in this room and you're not metabolically healthy, do not leave this place and go to the Windjammer and chug a bunch of butter, okay? Well, I'm serious, because we get super excited because we hear these things that sound interesting, and we think, like, oh, that'd be fun, and we try experiments, and we put ourselves in really bad situations where we have these extreme reactions to them because we're not the person to test that thing or to do that thing, because that's not who we are, where we are yet. So I just want, really listen to that point key if you want to try something like that before you do it. Make sure that you fix the glaring issues that you're dealing with right now in this moment.
This question is coming from a male in their mid-80s. They're no carbs in their food. My fasting insulin is high, 15 to 25, and my weight has ballooned. Is there anything I can do to induce reduce weight?
Does he, we're not allowed to ask, are we? Well, there's so many details left out of that. So I would say if you're super active, like you do a lot, like hours and hours of like heavy yard work and things like that, that was very similar to my situation. I found that blunting cortisol with strategic carbs around that heavy intensity blunted the cortisol response, which helped lower my insulin and bring it down. I think my insulin right now, it's 3.7 is my insulin right now, last time I got it checked. And it used to be above 10, right? And so I was able to manipulate that with a targeted ketogenic diet approach. So if you're, I don't know your story and we don't get to know, boo, but if you're super active, and we can talk about this later if you want to come up and talk, but if you're super active, you could try that. Outside of that particular situation, I'd be curious to hear what the doctors have to say.
I'm going to ask you this. If we're coaching you, I'm going to ask you, where's your stress management, where's your movement, and where's your sleep? Because listen, only 80% of your overall health is based on what goes in your mouth. The other 20% is sleep, stress management, and movement. And it's funny, I've been thinking a lot lately about, so during COVID, I gained some weight. I gained about 12 or 14 pounds. And I started thinking, okay, I wasn't moving as much, and I wasn't doing lacrosse and football, and we were having the occasional drink a little bit more. But then I started thinking a couple months ago that we had, forget COVID, there were other things in our lives that were causing ridiculous amounts of stress. And as we've heard about cortisol and stuff, when you have those ridiculously high amounts of stress, if you can't deal with that, I don't care where your diet is, you're not going to lose weight. And so I would ask you to, I would look at that as a health coach, I would look at where's your sleep, where's your stress management, where's your movement, because those are, my diet's on point, but I can tell you I've struggled with sleep and I struggle with stress management.
Yeah, that's good.
Yeah, so we should quantify those things. So sleep, 1.5 hours of sleep deprivation will lead you to have higher ghrelin, higher insulin, and eat roughly about 300 calories. I hate that word, but calories worth of food a day. So 1.5 hour of sleep, which is very common in the geriatric population. The other thing that's very common, which I hate to invoke John Bikman, but in the 6th and 7th decade of life, metabolism seems to downregulate by about 200 to 300 calories. So if you were 50 years old, eating a French cruller, now you're 80 years old, not eating that French cruller, you'd be sort of at the same place. So you're eating less, and you face a more difficult battle. And then the last thing, so the sleep difficulties that happen as you age is paramount, so I cannot echo that enough. There are also just the energy expenditure changes as you age, you need to take into account. And then the other thing that I think often goes unrecognized is as we age, the frontal cortex just shrinks. This is part of aging, right? It shouldn't shrink to a huge degree, but as that frontal cortex shrinks, and cognition sort of just becomes impaired, you become less inhibited and more likely to go for sweet cravings. So I think figuring out how to address the sweet cravings, really honing in on the environment would be the thing that I would focus on. And then it's going to take much longer, given I think the things that I mentioned earlier about the metabolism dropping. Whatever intervention you do, it may take months to see the fruit of that, so be patient.
Be patient, that's good.
Yes, it's difficult to give any tips without knowing more. I don't know where this person is coming from. I assume this person is already on a low carb diet and engaging in some strength exercise, because strength exercises actually can stimulate insulin sensitivity more, just because the muscle works as a glucose sink even when you are not moving. So I think prioritizing nutrition, low carb nutrition and strength exercise, especially in your 80s. My mom is 83 years old. I hired a trainer for her. She's training every day, and I have her take protein supplements because she doesn't eat enough. So a problem when you get old is that you also don't want to eat protein. Protein is more difficult to digest. It takes more time. As we age, also our pH in the gut gets higher, so we digest more slowly. It's just my mom doesn't want to eat protein, so I have her take protein supplements, take pictures of what she eats at every meal, send it to me. Yes, and she, and she's having, so she's experiencing a lot of improvements. She was also insulin resistant, so I think these are all factors to consider, in addition, of course, to sleep and other factors.
Yeah, let me just, not rather than from a coaching perspective, share a sort of teaching perspective too. There have been multiple really great points made, including the reduction of muscle mass. That is going to matter, as Lucia described it perfectly. It's a glucose sink. 80% of the reduction in glucose after you've spiked it is because of what the muscle's taking in. It is by far the main consumer of blood glucose when you have an excursion up. The more you start to lose that muscle mass with age, the harder that gets to correct. And so any given, the same food is going to have a much more delayed or more dramatic response. So you want to keep the muscle, and we do become resistant to the dietary protein. This has been adequately shown in humans. You actually need more. A 20-year-old can absorb protein better than an 80-year-old, and the 80-year-old needs to eat more protein than they did by unit per kilogram body weight than they did when they were younger. But also, just one last little teaching idea, the number of fat cells we have is generally quite static. The moment we come out of puberty, so mid-teens, girls, late teens, early 20s, and boys. Some boys are still not done puberty, even in their early 20s. And the number of fat cells we have then is typically the number we're going to have for the next 50 years. A fat cell will live about 10 years. They're not immortal. It will die, and it will be replaced by another one. It's a one-to-one change until about late 60s, 70s. Then the number of fat cells we have starts to go down. That's an important moment then, because if we're still eating the same way, that means the metabolic burden on the remaining fat cells starts to go up. In other words, the fat cells will start to hypertrophy, contributing to greater and accelerated insulin resistance and metabolic disarray. So let that be some degree of encouragement.
This question is for Dr. Bikman. My goal is complete metabolic health. I am 2 years in a committed carnivore with 0 sugar, sweeteners, or cheating. My blood sugar is now very even, and I have lost more than 50 pounds. However, while all my other blood work has improved, my insulin and blood sugar numbers are exactly where they were when I started. Fasting insulin is 9, fasting glucose 95 to 105, and A1C is 5.8, and my weight has been stalled for a year. I'm moderately active, sleep well, have a low stress life, and a job that I enjoy. I've seen people eating the way I do drop down to much lower and more normal insulin glucose A1C long before I have. What could be possible reasons why this isn't happening for me? I know there are things I could do. I'm more interested in what makes me different than the person who is fasting insulin of 5 and a fasting glucose of 70 while eating a 0 carb diet, especially after 2 years of faithful carnivore.
Okay, yeah, so some quick thoughts so that I give time for the others. I would say fasting insulin of 9 is pretty good. One of the problems with insulin is that it is unfortunately quite volatile. It has one of the more substantial circadian rhythms when it comes to metabolic hormones. And so it's very possible that you are continuing to simply catch it at a high point. If you're consistently getting it measured at the same time, it might really be worth getting it measured a couple hours later. And I wouldn't be surprised at all if it is in fact much lower. But that's all the more reason to rely on more stable markers like the triglyceride to HDL ratio. That is a really good surrogate marker for fasting insulin. So if you have a fasting insulin of 9, which is a little higher than I would say is ideal, but it's in that kind of medium range, But I put it in that medium range because it's, I think, within a margin of error. But all the more reason to look at the triglyceride to HDL ratio. And as Lucia showed the numbers, if it's less than 1.5 or if it's less than 1, you're laughing. That is a fine insulin number. You are just catching it at a high point. Now, with regards to the glucose, I think it is telling that the standards for what is an ideal glucose level over the decades has been coming down. Now, there is a generous view to that and a cynical view, and increasingly when it comes to medical entities, I'm quite cynical. Why was type 2 diabetes once upon a time only diagnosed with a glucose level of 150? Now it's at 126. Maybe it's because they made some seminal findings, or maybe it's because the sooner they diagnose someone, the sooner they can put them on a drug, and the more earlier someone's making money. So I increasingly think that glucose levels, having that 80 number in mind, is probably not really valid. That I think that it's entirely possible that people in their 90s or even low hundreds are perfectly healthy at that level. But lastly, with A1C, there's one component to A1C that we always forget, maybe not here. We often look at it, or conventional thinking looks at A1C as purely a marker of glucose numbers. But what if it is, at the same time, a marker of the longevity of your red blood cells? After all, if you have red blood cells that live long because you eat abundant omega-3 fats and a bunch of healthy fats, especially from natural sources, including phospholipids, you may have red blood cells that live longer. And the longer a red blood cell lives, the more likely it is to have a hemoglobin that gets glycosylated. It doesn't kill the red blood cell. It is still capable of transporting gases. It's not like it's a dead or useless or harmful red blood cell. It's supposed to be an indicator of glucose. But again, what if it really is an indicator of how long your red blood cells are living? And the more you're eating heme, iron, and healthy natural fats, it's not a stretch to say that those red blood cells are going to be more robust. In contrast, you could have a vegan who's incredibly nutrient deficient, whose red blood cells are dying all the time. Even though they may be hyperglycemic, they're not giving their red blood cells long enough to live in order to get glycosylated. Thus, they end up finding a false negative.
Okay, so we have time for one more. If your question didn't get answered, good news. You're locked on the ship for 2 more days with these. Okay. So Dr. Tro, can you please discuss the pros and, if any, cons of a statin? My doctor wants me on it, but I'm thinking there are better alternatives. Low carb staff, are the presenter slides available somewhere?
Okay, statins. You want the good first or the bad first? Bad.
Give me my
Okay.
veggies first.
They are an incredible cause of muscle aches, muscle damage. They cause liver damage. Okay. They induce insulin resistance. They raise blood sugar. They deplete CoQ10. They deplete K2. Cognitive impairment, which is reversible.
They inhibit GLP-1.
They inhibit GLP-1. Thank you. So that's about all the bad I can think of. There's probably more. Okay. Is that not? It's an interesting question, right? In who, right? So in who, I think, is the question. If you look at the WASCOP study and a lot of the studies for statins, it's one of the only class of lipid-lowering drugs that have an all-cause mortality reduction, which means that they actually save lives in people who have plaques. So would I take a statin? Probably not. When would I take a statin? If I knew I had soft plaques. How do statins likely decrease cardiovascular mortality? They actually calcify plaques. So this is a bad thing if you're trying to reverse soft plaque, and it's a great thing if you intend on living a diabetic life for the rest of your life, because you're going to develop more soft plaques. You want that plaque to be hard. It's sort of like a cement truck. It also seems to work on the nitric oxide pathway as well. So the good and the bad is, when would I use it? If I had a very high calcium score and evidence of soft plaque, I would consider it. But it makes people feel terrible. So, and there are other drugs, like Dom mentioned, like ezetimibe, which have also been shown to reduce plaque volume, like literally shrink plaques, that don't have as many side effects. There's other drugs that actually reduce soft plaques. So prescription grade EPA, which is called Vasipa, has been shown to reduce soft plaques. Literally, plaques in your artery, 18 months later, plaques gone. There are other drugs that are a little bit more elegant, I'd say, from a pharmacologic perspective, which are the PCSK9 inhibitors. They're injection antibodies that also have been shown to reduce plaque volume. The problem with all of those drugs is they've never been shown to save lives, none of them. So the PCSK9 inhibitors reduce LDL very much. They make the blood look great. Your cardiologist will be ecstatic. Your LDL is 20. But it's never been shown to reduce cardiovascular mortality even, which is a pretty high hurdle, which is a pretty low hurdle for a lipid-lowering drug. So bottom line is we have multiple classes of medications that make your numbers look good and they don't do much and they have potentially have side effects. Statins, they have potential benefits. They actually save lives in some studies, others not. But the cost, the adverse events, is very high. So most people they just don't want that, right? Most of us here don't want to be on drugs, especially a drug that makes me feel like crap. There are other options, Zetia, besides allergic reactions that don't make people feel like crap. And especially if you're low carb, we found sort of hyper responders like Don mentioned. So you may get more of a bang for your buck, and you'd get none of the sort of myalgias, cognitive impairment. It's not the only. There are other drugs, like I said, prescription grade fish oil that has some side effects too. It can cause atrial arrhythmias. So nothing is without side effects. So I think but back to the question with statins, who would benefit? There's evidence from the St. Francis Heart Study that the more coronary calcium you have, the more likely you are to benefit. The more severe your diabetes, despite lifestyle intervention, the more likely you are to benefit. But it comes at a high cost. I hope that answers the question.
Can we give it up for our speakers?
Before we let them go, this is something that I asked everybody in our last session. I know, it's just being married to me. What is your favorite go-to meal? You gotta make dinner tonight. The Windjammer is not gonna make it for you. Main Dining's not making it. What is your go-to meal with this, the schedules that you have? We'll start with Dr. Bikman. Just walk this way.
I don't know. Yeah, so I have a unique role in my family where I am the primary meal prep and cleaner, mind you. My wife does other things. I do those things. But my go-to meal is tri-tip and vegetables. Tri-tip and vegetables. I have a Traeger grill and we use that all the time. That's probably my go-to. I love tri-tip. Otherwise, frankly, if it's not a tri-tip steak, I prefer hamburger. I don't really care for other steaks. Isn't that terrible? I just kind of tri-tip or bust from those go-to. That's my go-to.
Yeah, for me, it's a mix of fish, salmon and white fish with lots of olive oil. I pick my olive oil. I found a store in California where I taste different olive oils. There is the polyphenol content on the bottle. The highest the polyphenol content, the most pungent and strong is the flavor. And I just have that with lots of olive oil, some vegetables. I'm happy.
If I don't have time, I pull up to McDonald's, I ask for 8 hamburger patties. Don't put anything on the grill, just cook it like that, throw salt on it, give me a side of pickles. If I have time, I prefer, something like Dr. Aronica.
Go-to meal, not favorite meal.
Go-to meal.
Okay, go-to meal would be air-fried chicken thighs with turnips and olive oil.
Mine is super simple. It is ground beef. I think ground beef is super easy. And you can do a lot with it. So we always actually keep a bunch of ground beef already cooked up, and then I can grab it and I can put whatever spice, condiment, or anything else I want, and I can literally take ground beef and have a different meal every single day.
Mine would be whipped cream.
Yeah,
Y'all think she's kidding? Like almost a can a day.
There you go. So thank you guys so much. Have you had fun?
Are we having a low carb group 2025?